So deep gluteal syndrome is entrapment of the sciatic nerve, which is due to non-discogenic causes. The symptoms is usually pain and dysesthesia in the buttock area, hip or thigh. It is atypical radicular pain. Etiology, the most common cause is piriformis muscle, and we have some what we call anatomical variants of the piriformis muscle, starting with the usual anatomy we know, by which the sciatic nerve passes behind the piriformis muscle. And we have other 5 anatomical variants starting with B, C, D, E, and F. There is other rare causes of deep gluteal syndrome, such as the hamstring muscle, the gemini obturator internal complex, ischial tuberosity, and sometimes the acetabular reconstruction surgery. Clinically, we can use 2 special tests, like the active piriformis test. The patient do resisted abduction, external rotation, while pushing his heel towards the examination table, and the examiner can palpate the deep gluteal space over here. The test is positive if there is pain in the space and if the patient develop what we call a sciatica or radicular pain. And other important test is the seated piriformis stretch test. Here is passive flexion, adduction, internal rotation of the hip while the knee is extended. And the patient can palpate also the deep gluteal space. The test is positive when there is pain in the deep gluteal region, and after a few seconds the patient can develop like a paresthesia or a sciatica-like pain. So we can say that when no other causes like lumbar causes, those patients we should examine carefully for the lumbar spine. Sometimes we do MRI. Piriformis syndrome could be established by physical examination and injection test. Sometimes some authors use MR neurography, which might be helpful in selected patients with sciatica as an aid to diagnose. Treatment can be conservative, doing piriformis stretched exercising, as in this photo, and if if there is no response, endoscopy allows decompression of the deep gluteal space. Coming to our case, which is 35 years old male. He has a sciatica-like pain. He has a positive seated piriform stretch test, as we already mentioned. He has pain in the deep gluteal region, and after a few seconds, he had developed a radicular pain. His X-ray was quite normal, also the MRI, nothing major. His pain was relieved after injection for about 2 months, but it recurred with failed physiotherapy. So we decided to do endoscopic decompression. We use the supine position. We use the anterolateral portal, posterolateral portal for establishing the other portals, which is the auxiliary posterolateral portal and the distal posterolateral portal. Starting to do what we call bursectomy for the region, because usually the bursa here is inflamed and obscuring the vision. We sometimes need a fluoroscopic control in order to reach the tip of the greater trochanter by which the piriformis tendon inserts. This is a video for intraoperative results. We start to do like decompression of the piriformis tendon. We start to do bursectomy for the bursal tissue here, and also we start to do to elevate the gluteus medius, which usually overhanging the piriformis tendon over here. And after some time, the piriformis tendon start to appear, and we can see it clearly, and start to mobilize and getting more release for it. It's quite not easy to find it, especially if there is a lot of inflammation and bursitis, as we can see. After gaining a good mobilization of the piriformis tendon, we do a release. And I didn't seek to see the sciatic nerve because I feel it's quite risky. It's one of our first case. And after 3 months, the patient have improved symptoms, and he has negative seated piriform stretch test. And now he is doing physiotherapy without pain or radicular pain as before. Thank you.
Thank you, Ahmed.